So our first speaker for this session is Dr. Thuy Lee, and the title of her presentation is Strategies to Reduce the Burden of HIV-Associated Talaromycosis in Asia. Welcome.
Good morning. Thank you very much. It's a pleasure to be here to give this talk with you, and I'm looking forward to meeting many of you as the day goes by. I thought, since I'm new to Duke, I'll give you a little bit about an introduction of my academic career. So I had a very early interest in infectious diseases and public health. I spent a year at the CDC on an emerging infectious disease program. This is prior to medical school. And then I did my internal medicine at Tufts in Boston, infectious disease training at Yale, where I studied with Gerald Freeland and Mike Kozo. Some of you may know them, but this is where I really consolidated my interest in HIV. Then I did a fellowship with the Fogarty International Research Fellowship, but I was based not at the NIH, but in Vietnam, in the Oxford University Clinical Research Unit. So this is a more than 25 years program funded by the Wellcome Trust of the Oxford University, and basically focus on tropical medicine. I did my PhD in epidemiology, and earlier this year I came back to the US and joined Duke. And such a pleasure, because Duke has the world best, I think, clinical and basic science program in mycology, and I'm very excited to be here. I wanted to give you a little bit about introduction about the Oxford University Clinical Research Unit. So here we are. Oops, sorry. What did I do? Okay. So that's the building which is inside the hospital, and it's a clinical laboratory of the hospital. So we are a few steps away from the hospital, from patients. And the hospital is a 600-bed referral center for tropical infectious diseases in southern Vietnam, with a catchment population of 40 million people. So you can imagine that we do see all sorts of different tropical infections. Serious infection, and this hospital is also the place where we saw the first cases of SARS and H5N1s and other emerging infectious diseases. This graph shows the mortality at our hospital over a 14 years period, and as you can see, mortality began to decrease, and that's due to reduction in mortality due to typhoid fevers and malaria. But then in the late 90s to the 2000s, we begin to see an increase in mortality, and that was due to HIV in blue, as you can see. And when we look at causes of death, tuberculosis made up nearly 40% of death, and followed by invasive mycoses. And the major three that we see are cryptococcosis, talaromycosis. The previous name is penicilliosis, in case you not familiar with the new name, and pneumocystosis. So these are the major cause of death in our HIV-infected patients. And these are really what drive our research, and we are focused on clinical trials that are powered to address important clinical outcomes that inform treatment guideline for tuberculosis, bacterial meningitis, cryptococcosis, and talaromycosis. So we are interested in clinical trials that are very relevant and inform guideline. And my research interest is focused on talaromycosis. But interestingly, I didn't come to Vietnam to study talaromycosis. Actually, it was to study HIV drug resistance. And I just came to see many patients with these conditions and began to develop an interest and started the basic description, epidemiological description of the disease, and one thing led to another, became completely deeply committed to this disease, to studying this disease. So talaromycosis is one of the 7 endemic mycoses that are of medical importance, and it's specifically restricted to Southeast Asia. So all countries in Southeast Asia are infected and affected, with the countries in red. So you can see southern China, throughout Vietnam and northern Thailand are the hotbeds of infections, and we don't quite understand why. So these are the geographic distribution of the 7 major endemic mycoses in the world. And as you could see, North and South America have 5 of them. So we have coccidiomycosis, histoplasmosis, paracoxes in South America, blastomycosis, and sporophycosis. So North and South America, we really are the hotbeds of all these endemic mycoses. And then you have talaromycosis in Southeast Asia and emergomycosis in South Africa. And they share very similar characteristics. So they are geographically restricted. They have a very intimate relationship with the ecology, the soil and ecology makeup of the place. And they are dimorphic, meaning they're actually thermally dimorphic, meaning they're able to switch from a mold in the environment to a yeast form when they parasite the host. And that switch occurs by temperature, and they all behave similarly. And they're able to infect both immunocompetent and immunocompromised, but predominantly immunocompromised patients. So studying one of them can really give you an idea of what's going on, and that what you learn from one disease can be applied to others. And that is what really interesting to me the more I study this pathogen. So a little bit of history. It was discovered in 1956 in Vietnam at the Pasteur Institute in Vietnam, in the Highland City, where microbiologists were studying Susugamushi fever. So they used the wild bamboo rat caught in the highland for an experimental model, and they identified the pathogens in the liver and spleens of these bamboo rat. And they behave culturally just like penicillium, but interestingly, they grow as a yeast at 37 degrees, and that's the only penicillium species that behave like this out of more than 300 penicillium species. So it's very unique, and they describe that. This is Segression sitting right here, celebrating his discovery at Pasteur Institute in Paris. And it was a very rare infection. Actually, the first 2 cases was from American who had, one had lymphoma, and at the time, I think in 1973, he had lymphoma, and at that time, Hodgkin lymphoma treatment is to remove the spleen, and as they remove his spleen, they identify these nodules and diagnose the first human cases of talaromycosis in the US, actually, followed by 6 years later by someone in South Carolina with lung problem. And then it's rare cases report during the same time in the 80s in Southeast Asia. But really the disease didn't really became prevalent until HIV epidemic arrived. And as you could see, the very close temporal relationship between HIV and talaromycosis in northern Thailand and also in southern Vietnam. And it's quickly become number 3 most common opportunistic infection in HIV patients with advanced HIV. The case mortality rate is very high. Without treatments, 100% mortality and up to 30% with antifungal therapy. In southern China, the disease seemed to confine in southern China in certain provinces of the highland. And this data came from Guangzhou Hospital and Dr. Linghua Li, a collaborator. And as you could see, the epidemic curve here, I was struck by the number of AIDS cases in China. AIDS cases are increasing in China along with talaromycosis, and last year alone, there's more than 250 cases of this infection at that hospital. So it's a real problem that we see. In terms of global burden of talaromycosis, this is an ongoing project that we're doing. It's very difficult to estimate disease burden based on case report, as you know. And particularly with the hotspot area, not regions, not all regions are the same, and without serologic assay, it's very difficult to estimate disease burden, but we'll try our best, and we identify more than 21,000 cases so far in 33 countries, and 99% are from Asia, and the 3 highest countries are in China, Thailand, and Vietnam. The rest, all patient, almost everybody except for one, had a histories of travel to the endemic region. 10 to 20% of patients are non-HIV, so we begin to see an emerging epidemic in non-HIV patient with primary, secondary immune deficiency conditions, and we do see it in children up to 6%. In terms of clinical manifestations, this is a cohort at our hospital of more than 500. The disease has a subacute onset, so it can take weeks and weeks. And a lot of these patients, when we go back to look, they have been in the hospital multiple times for fever of unknown origin, and every culture is a negative. And they eventually come back with either a skin lesion, which is a very late manifestation of disease, blood cultures and other culture become positive. By then, it's very late. So early diagnosis is a big problem for these conditions. They present with constitutional symptoms, and 70% of patients at the time of diagnosis have skin lesions, so up to 30 to 40% of patient diagnosis is made by blood culture. They have multi-system disease, but mostly involve the reticular endothelial system, because that's how the pathogen disseminate through the macrophage and go through the lymphatic system and disseminate through the liver, spleen, bone marrow, causing bone marrow suppression with anemia, thrombocytopenia, etc. We see this in very advanced HIV with CD4 count of 7. So this is very late stage. In terms of treatments at our hospital, even though we are the Eiffel Tower of Vietnam, we use itraconazole 60% of the time, and only 30% of patients get amphotericin B, mostly because of lack of availability, and a lot of clinicians are not happy using ampho B because of a lot of side effects. In-hospital mortality on this case series was up to 28%. We do see paradoxical immune reconstitution syndrome that similar to tuberculosis and cryptococcosis or CMV. We do see this phenomenon as the patient respond to antiretroviral therapy. They can present within 3 to 4 months of treatment with inflammatory paradoxical worsening of disease, and these are some of the manifestations, and we're trying to, right now with funding from CFA, trying to understand the immunological profile of these patients and see if we can predict the disease somehow. So in terms of research, I focus on reducing incidence and mortality, and we do this by developing novel diagnostic, developing prognostic tool, clinical trial, incorporating understanding of drug-resistant antifungal susceptibility testing, understanding pharmacokinetic, pharmacodynamic, and we try to eventually prevent disease from developing, and that is with epidemiology and understanding pathogenesis. And these are all areas that I have the ambition to tackle, and certainly with pathogenesis is a reason why I came to Duke. I'm going to summarize my whole PhD in one slide very quickly, and I'm going to try. But this is to give you descriptions of this pathogen. It has 2 lifestyles, so it has a saprophytic lifestyle in the environment, and it has a very unique ecological niche in the highland area, and it basically humidity is what predicts high incidence of disease in the region. So we believe that humidity and rainy season, when we see a 30 to 50% increase in cases, actually enable the environmental reservoir to expand, and that causing more infection in human. And it actually take advantage of bamboo rats, and these are burrowing animals that live in the highland to expand its own geography and biomass, because the pathogen doesn't survive very well in the soil, and it needs help, and it needs food, and it take advantage of the bamboo rats. They actually colonize bamboo rat in the liver and lung, and the bamboo rats are healthy and running around. But then they shed the pathogen in the stool, and when the bamboo rat die, it serves as the food source for the fungus. In human, you get infected because we travel through the regions and inhale the spore in the environment. And we've done the case control studies and with some other data from Thailand that show that exposure to plants and animal and travel to these highland regions put the patient at risk, and these are unpublished data. But when it gets into the human body, it switches to a yeast form and multiply very quickly and able to multiply in every organs and causing problem, disseminated disease. In healthy people with an intact immune system, it can cause a latent infection that reactivates many years later. So the main limitation of diagnosis is that I mentioned microscopy is only, skin lesions only present in 70% of patients at best. And so some patients you rely on blood cultures, and blood culture take up to 14 days. And with these disseminated disease, early treatment and diagnosis is massively important, and that's a very big challenge for the field. We've developed several novel assays, and one of them is a very simple quantitative fungal count. And this is basically just serial dilutions directly from patient blood and plot them in tiny dot on the plate and put them on an incubator, and you're able to count the colony forming unit and actually quantify the fungal load in patient blood. And later on, I'll show you how important that is. In terms of molecular assay, there's PCR has been developed, and we developed one of them here that was published last year. The problem with PCR for fungal infection is that PCR is very specific because it's molecular based, but the problem is that sensitivity is not good because we don't have a high fungal load in the blood. And also because the fungus has a very thick wall and it's very difficult to break the cell wall to get the DNA to release. So our sensitivity is up to 70% at max, and that's not as good. Well, that's come close to cultures. But it's rapid, definitely not a 14-day thing. So it still has a play in terms of rapid diagnosis. But none of these tests has been standardized. I do think, though, immunoassay antigen detection is the way to go for fungal infections, as we have example in Cryptococcus with a very quick lateral flow antigen detection assay that is very sensitive and specific. Aspergillus, we have galactomannan assays, and also in Canada. So I think antigen detection is the way to go. It's much more difficult for endemic mycosis, though. But recently there's a monoclonal antibody developed by a group in Hong Kong. It's based on a protein in the cell wall that is abundantly released in the circulation, and it can be detected in the blood and in the urine. And this group in Hong Kong have screened more than 8,000 patients, and this is serum, Bang Sera, and they identified 9% positivity, but didn't have the clinical data. So what we did was we validated this assay using our cohort. And as you see in this graph, the case is almost 380 patients with culture-confirmed disease, and controls are people who we absolutely certain don't have the disease, so including healthies and people with a spectrum of other infection. And as you could see that the assay performed very well. Sensitivity is 86%, not perfect, but it's a lot better than blood cultures, and you can get this result in 6 hours. So it's fantastic, and specificity is 98%. So this is really good news, and we need to do more prospective validation to understand the clinical utility of this test when we actually test them in real time in patients who come in with suspected fungal infection. This is a study we performed to understand whether we can use this test to screen for disease in asymptomatic folks with a CD4 count less than 100. And we did this in a cohort of more than 1,000 patients who participate in a cryptococcal screening implementation studies in Vietnam at 22 clinics in Vietnam, and we identify 4.2% anagenemia prevalence, and those are the circle that show you the prevalence. We see more disease in northern versus southern Vietnam, and when the patient is positive, the antigen level is very high, suggesting that it's clinically significant. And then we recently conducted a mortality outcome in a 12-month in more than 1,000 patients. Anagenemia at baseline, this is asymptomatic, was an independent predictor of death. And you can see the Kaplan-Meier curves separating between antigen-positive and antigen-negative patients. And this is independent of positive cryptoantigen and low CD4 count and older age. So this is really exciting because this tells you it's not a causal effect. It doesn't tell me that anagenemia is the cause of mortality, but suggests that patient with anagenemia would develop disease if not treated. And if we can use this test to screen for disease like we do right now for crypto, we could substantially reduce morbidity and mortality. And this is a basis for the grant application that I'm putting in to the NIH to study this phenomenon, screening people with low CD4 count, asymptomatic, and study the natural progression of disease. Quickly go through treatment. International guideline recommend treatment with amphotericin B for 2 weeks, followed by itraconazole. And that international guideline was based on one non-comparative study done 20 years ago in Thailand in 74 patients. And they found treatment response was 97%. In Vietnam, as you remember, 60% of our patients were treated with itraconazole. And in large case series in the region, there's no difference in mortality or clinical outcome. So that's why we did this study, because if we can treat this with itraconazole, we could really treat many more patients without hospitalization and side effects. So we did the studies and we found, I know I ran out of time here, that mortality is significantly different at 6 months, 21% in M4B and 11% in itraconazole, and that significantly changed treatment guideline for this disease. And we found the quantitative fungal assay that we developed show a correlation significantly faster fungal clearance in the blood in the M4B arm. And this is my last slide. We are collaborating with Dr. Kleburn and Shang-Xin Tu, who is a master student at the CFAR. She's a summer CFAR student, and try to look at the dynamic of fungal clearance to identify the surrogate marker of mortality. Can we identify a surrogate marker to help us conduct early trial for this disease without doing a very big 500 patient clinical trial that power for mortality? So in summary, talaromycosis is a leading cause of HIV-associated morbidity and mortality in Asia, driven mainly by high burden of advanced HIV disease in the region, and also emerging populations with primary or secondary immune deficiency conditions. The MP1P ELISA is a very promising diagnostic assay that can be used as a screening tool for prevention of disease. Initial treatment with M4B achieved rapid fungal clearance in blood and reduced long-term morbidity and mortality. And the speed of achieving the fungicidal effect, as identified by our CFAR students, is a very important predictors of all-cause mortality, and that could be a surrogate marker for further trial. And I want to thank all the collaborators and our research funder. Thank you for your attention.
Thank you, Thuy. Do we have time for one question, if anyone has a question? What's the opportunity to develop a vaccine for this pathogen?
Yeah, so in order to develop a vaccine, I guess you have to identify immunogenic proteins, and immunology as well as basic science aspect of this disease is even more neglected than clinical research. But there's effort, and I think that it would it would serve the 7 endemic mycosis very well, given how similar they are.
Thank you.
Thank you.